Okay, so today's topic for the demo class is diabetic ketoacidosis. So I cannot emphasize enough the importance of this topic for the both FOP as well as TAS exam. If you have one topic to study from endocrine for both the TAS as well as for FOP, you have to study diabetic ketoacidosis. The topic is same, but the pattern of question will be different in both the exams. For the TAS exam, you need to know the pathophysiology of the diabetic ketoacidosis, and for the FOP exam, basically the clinical scenarios and sign and symptoms, investigation, and what is the treatment you will give. So let us study diabetic ketoacidosis today. And before studying this topic, I want to say a very important thing to you, that this is something that I have been following since my medical school, and I have decided I'm going to always follow this. That is, good basics never fail. This is one thing that you always have to keep in mind. No matter where you go, what specialty you choose to be in, you should always have a good basic. It's like having good faith in something. That is to me. So if you have good basic idea about any disease, any case, you will be able to take it for a very long time. I'll give an example. Say a disease named primary ciliary dyskinesia. So what do you know about this? If you just go and start studying the sign and symptoms and then the investigation, treatment, there are first line, second line, conformity, you might forget it. It's very hard. It's a matter of time. You have to repeat it. So if you know by the word, by the name itself, primary ciliary dyskinesia, so there is something wrong. Primarily there is something wrong with the cilia. So you got to understand where are cilia present in the body. In the brain, in the respiratory tract, in the genital tract, and some other places. So of course the patient will then present with symptoms of these systems. So this is the basic for everything. If you have an understanding of the basic, of course I'm not telling you that read the entire book, study everything, mug up everything. No, that's not possible. Just a basic idea. For example, what is diabetes here? Diabetes means a lack of insulin, either complete lack of insulin, partial lack of insulin, or the patient may be insulin resistant. And then ketoacidosis. What is ketoacidosis? When a patient with diabetes suffers from excessive ketone in the body and it leads to acidosis. So that is diabetic ketoacidosis. This is the basic thing here, okay? So let us dive into it. Following our main aim is good basics never fail. You should always understand this, and let us start. Okay, so this is one mechanism that you need to know. Okay, have a good idea of insulin. Since we are studying about diabetes, of course how you need to treat the patient is by insulin. So what is the mechanism of insulin is that insulin always shifts the glucose into the cell. So when the glucose increases in the blood, so that is diabetes, there will be hyperglycemia, so we give insulin. So the mechanism of insulin is insulin will shift the glucose from the extracellular to the intracellular fluid. So the glucose concentration in the extracellular fluid will become normal. Also, one additional mechanism I want to say here, because it will be asked in the question and we'll be solving certain questions here. Insulin also have a similar mechanism towards potassium. So insulin also shifts the potassium into the cell from outside the cell. So when there is hyperglycemia, insulin will shift the glucose from extracellular to the intracellular space. Even when the potassium is normal, the action of insulin is it will shift the potassium from extracellular to intracellular space. So in this way, there will be hypokalemia because of use of insulin. There will be normoglycemia after using insulin. It can lead to hypoglycemia, but there will definitely be a hypokalemia in insulin. Okay, now let us look at what are the basic function of insulin in our body. Okay, so this is the anabolic effect of insulin. You need to have a good idea about this. So insulin acts on multiple systems, as you can see. So it is acting on, so insulin is acting on the skeletal okay, it is acting on the skeletal muscles, and it increases the glycogenesis. So what is glycogenesis? I know every one of you know who are seeing this video, but just for the freshers and just for a reminder, glycogenesis means production of glucose, conversion of glucose into glycogen. So glycogen is the storage form of glucose. So what insulin does, it reduces the glucose. How? It will convert the glucose into glycogen. That is called glycogenesis, and it will increase the protein synthesis synthesis in the skeletal muscle. Now we have in the liver, insulin acts on the liver, increases glycogenesis. Again, it will convert the glucose into glycogen and increase glycogen synthesis. And it will reduce the gluconeogenesis. Now what is gluconeogenesis? Is the production of glucose from non-glucose substances such as amino acid from fat amino acids. So it will reduce the production of glucose because insulin is used in hyperglycemia. We want to reduce the amount of glucose. So it will reduce the gluconeogenesis. Now in the adipose tissue, insulin has some functions such as it will reduce lipolysis. So why is it reducing lipolysis? Because when there is increased lipolysis, there will be increased free fatty acid. When there is increased free fatty acid, there will be increased ketone body. Also, the lipid metabolic pathway is closely associated with the carbohydrate metabolic pathway. So in this way, it will reduce the lipolysis and it will increase the adipogenesis. That means it will increase the formation of lipid. So this is about insulin. You need to keep in mind that insulin will increase glycogenesis, reduce gluconeogenesis, increase protein synthesis and decrease lipolysis. So it is overall, you can see it's an anabolic hormone. It is formation of everything. It goes against lysis. It is almost everything. It is just formation. It is genesis. Okay. Now this is the thing that you need to remember about insulin. Now let us look at the pathophysiology of diabetes. Now yes, this is very important. So once you know the function of insulin, this is going to be a lot easier to you. Why do we need to know? To have an idea, because questions will be asked from here. Okay. So when a person is having diabetes, forget about this counter-regulatory hormones. Focus on this. So person with diabetes, so mostly children with type 1 diabetes, sometimes they present with directly diabetic ketoacidosis. They are not previously diagnosed as a diabetic patient, but they will present with diabetic ketoacidosis. Now what is the pathophysiology? So since the patient is diabetic, there will be decreased in insulin in the body. So when there is decrease in insulin, there will be increase in glycogenolysis. So more and more breakage of the glycogen to convert into glucose. That will lead to hyperglycemia. Okay. So insulin also shifts the glucose inside the cell. That means in the absence of insulin, glucose will remain out of the cell and there will be no utilization of glucose by the cell. So decreased utilization of glucose, more and more glucose outside the cell. That will lead to hyperglycemia, increased glucose in the blood. Also we saw that insulin reduces lipolysis, but since there is no insulin now, so it will increase lipolysis. When there is increased lipolysis, there is increased free fatty acid. When there is increased free fatty acid, that will cause gluconeogenesis. Also it will cause ketosis. Ketosis will lead to ketoacidosis. Okay. Insulin deficiency also lead to protein lysis. So there will be protein lysis, decreased protein synthesis. So we know that gluconeogenesis is the production of glucose from non-glucose substances such as fat and protein. So increase amount of extra amino acid and increase amount of free fatty acid, that will lead to gluconeogenesis. And all these ultimately will lead to hyperglycemia. So that is why a patient with diabetic ketoacidosis presents with hyperglycemia. So whenever there is hyperglycemia, there will be associated hyponatremia, because the water shifts out the cell secondary to glucose. Every 3.5 glucose is gone. So this is the mechanism that whenever there is increased glucose in the blood, there will be loss of sodium. So that is why there will be associated hyponatremia. I'll tell about this mechanism later. So when there is hyperglycemia, it leads to glycosuria. So glycosuria means more and more glucose is lost. That will lead to polyuria. When there is glycosuria, more and more fluid as well as glucose is lost. That will lead to dehydration, hypovolemia, and the child will suffer from dehydration and there will be polydipsia. So that is how a child with diabetic ketoacidosis presents. Will present with hyperglycemia, will present with dehydration and vomiting, polyuria, polydipsia, features of hyponatremia. Okay. So let us see from the guidelines, pediatric guidelines book, how a child of diabetic ketoacidosis presents. So this is the basic mechanism of diabetic ketoacidosis, where the decrease in insulin or deficiency of insulin leads to all the mechanism. Okay, if you have a good idea, then you will have, it will be swift, it will be very smooth for you. Now let us move. Now diabetic ketoacidosis. Now look at the recognition and assessment. How will you do? Sign and symptoms are thirst, that is there will be polydipsia, there is polyuria, weight loss, abdominal pain, vomiting, then there is tachypnea, sighing respiration or known as small breathing, order of ketones, dehydration, drowsiness, coma, biochemical signs. These are very important. There will be ketones in urine or blood, elevated blood glucose more than 11 millimole per liter. There will be acidemia, that is acidosis less than 7.3. These are the features. So not necessarily that patient will present with you with all these features. Also in the question sometimes they only pinpoint some of the features. For example, they'll tell you a 10-year-old girl has come to you with severe abdominal pain, vomiting, and she is drowsy, there is dehydration, and her blood glucose level is 30 or 40, and that's it. So you know, any patient coming drowsy, dehydration along with abdominal pain, you have to exclude you have to take the blood glucose and exclude DKA because it's an emergency. Okay, so they may not come with other features, they may not be exactly diagnosed as a case of diabetes mellitus, but they will often present with diabetic ketoacidosis. So these are the signs and symptoms and biochemical signs. Now we'll look at the algorithm of management of diabetic ketoacidosis. So don't get scared by seeing this huge table that is there in pediatric guidelines. You can see it's a 9-page guideline, but I have summarized it into a very small 2-3 pages because I actually wanted everyone to understand it. Okay, so we have it here. Yes, algorithm. So this is the algorithm of management of diabetic ketoacidosis. So you got a patient of diabetic ketoacidosis coming with all these features: abdominal pain, there is vomiting, dehydration, and blood glucose is high. Okay, you got a patient. Now you're suspecting diabetes by the sign and symptom. What are the sign and symptoms here? With history: polyuria, polydipsia, weight loss, abdominal pain, weakness, vomiting, confusion. And you will examine the patient. This is very important. You got to examine the patient to assess the dehydration. If there is any small breathing, smell of ketones from the breath, there is lethargy, drowsiness. Okay, if you are suspecting diabetes, you take the history, you do the examination. Yes, your suspicion is right. Then you do the test to confirm. What you will do? Biochemistry. You will test for RBS. So if the RBS is more than 11 millimole per liter and pH is less than 7.3, so you have diabetes here, you have acidosis here. Ketones are more than 3 millimole per liter, so you have diabetic ketoacidosis, all of these three. So you're confirmed. Along with that, you can do electrolyte, urea, and others according to the symptoms. So basically you have to do 3. One is the blood glucose level, one is pH, one is ketone body. Okay, you have done the test. Now you're confirming it. Yes, it is diabetic ketoacidosis. You're confirmed. Now you have to call your senior staff. Okay, and now you have to check the patient, whether the patient is presenting with diabetic ketoacidosis. Is he or she in shock or not? Because the management is divided. Now if the patient is in shock, what will you do? If the patient is in a shock, you got to maintain ABC. Okay, maintenance of airway with or without NG tube. You have to maintain the breathing by giving 100% of oxygen, and you have to maintain the circulation. So how will you maintain the circulation? The patient is in shock. This is the most important one. You have to give 20 ml per kg of sodium chloride to the patient as a IV bolus, initial bolus you have to give 20 ml per kg of sodium chloride. Okay, and after that you will start with the maintenance fluid deficit, total fluid. This is the initial bolus that you need to give if the child is in shock. Now if the child is not in shock, so what are the features of shock? Reduced peripheral pulse, volume, reduced conscious level, coma. So if the child does not have any of this, you will give only 10 ml per kg IV fluid bolus. Then you will give the total requirement of fluid. We'll correct it later, we'll calculate it later. So how you will give the fluid requirement? According to the percentage. So if the pH is less than 7.3, that means the child has mild DKA, so we assume it is 5% dehydration. And if the pH is less than 7.3, we assume the child has severe DKA and it is 10% dehydration. So you have to calculate the fluid accordingly, percentage of dehydration into the kg into 10, body weight into 10. You have to give the total fluid. Now if the child is in shock, you will give 20 ml per kg, right? You will not subtract this from the total fluid. But if the child is not in shock, the initial 10 ml per kg you are giving, right, that you will subtract from the total amount of fluid. And then okay, you have given the fluid. Now what else you will give? Since we have learned that insulin also causes hypokalemia, so we don't want the patient to go into hypokalemic shock, so we give him 20 millimole of potassium for every 500 ml of fluid. So if you are giving 1000 ml of fluid, so you'll give 40 ml of potassium. So along with that, first you give fluid, then you give potassium, and then what do you give? You give insulin. So you will not give the insulin instantly as the patient comes, as he or she is diagnosed. First you got to give the fluid, potassium. You will give IV insulin 0.05 to 0.1 unit 1 hour after commencing the IV fluids. This is very important. You have to give only after 1 to 2 hours. Okay, so you diagnose the patient, you are giving the fluid, potassium as well as the insulin. Now what will you do? You will monitor the patient. Okay, you will monitor the patient hourly, see the blood glucose, neurological status more than 1 hourly fluid input output you will check, and you will see the electrolytes, and 2 hourly you will assess the patient. Okay, now what to do after that? Now, as you monitor the patient, you have to look for the neurological deterioration. If the patient is having any neurological deterioration, neurological sign and symptoms. Now, what is the neurological risk in case of diabetic ketoacidosis? So, about 0.1 to 0.2% of patients do develop cerebral edema from diabetic ketoacidosis. Although the percentage is very low, but it is fatal, so we don't want the patient to develop such thing. So we have to keep in mind certain signs and symptoms. They are cerebral edema, warning signs, headache, irritability, slowing heart rate, reduced consciousness level, signs of raised intracranial pressure. So you have to keep in mind if this patient has all these symptoms. If this patient has the symptoms, yes, so you have to manage accordingly. What you will give? You will exclude hypoglycemia. You will make sure there is no hypoglycemia. Give sodium chloride 2.7%, or you will give mannitol 0.5 to 1% 1 gram per kg over 30 minutes. You will call the senior staff, restrict the fluid by 50%, and talk to the critical care specialist. So ultimately, if you see neurological deterioration, immediately you have to suspect cerebral edema. So cerebral edema, how do we treat? We have to restrict the fluid by 50%. We have to give mannitol, so more and more fluid will be excreted by osmotic diuresis, and you have to call the critical care specialist. Now, if the patient does not have the symptoms and he is improving, how do you know he is improving? The pH is static. Is the patient improving or not? Okay, so if the pH is static, if there is no reduction in ketones, no reduction in glucose, that means not improving. Patient is not improving. These are the signs. So if the patient is not improving, so you have to re-evaluate. Am I giving the correct fluid? Am I giving the correct amount of insulin? Is there any acidosis? Is it sepsis? So I will restart the protocol. Okay, but if the patient is improving, now you have to again check the blood glucose. The blood glucose less than 14 millimole or not. If it is less than 14 millimole, you have to give commence on 0.1 unit. You were commencing on 0.1 unit of insulin, you will reduce to 0.05 unit of insulin. You will reduce the insulin because blood glucose is falling, and then you will give 5% of glucose along with the sodium chloride that you were giving. Sodium chloride 500 ml with plus 20 millimole of potassium. Along with that, you will give 5% of glucose because the glucose is falling. Okay, again you will reassess the patient. Okay, again the blood glucose is less than 6 millimole per liter. If it is again less than 6 millimole per liter, you will add more glucose to the sodium. Now you will not reduce the insulin. Only if the if the ketones are more than 1 millimole, you will not reduce. Only if it is less than 1 millimole, you will reduce the insulin. So you will add more glucose, and you will adjust the insulin according to the ketone level. Okay. But if the blood glucose is not less than 6 millimole, that means the child is good. So you will keep monitoring the patient. Hourly you will check the blood glucose, you will check the electrolyte, neurological status, you will check input, output, and then IV fluid. Everything you will check at a regular basis. And then you need to see if the DKA is resolved, if this condition is resolving. So how do you know it is resolving? The child, he will be clinically well, drinking well, tolerating food, and blood ketones, it will be less than 3. Blood ketones will come back to normal. So if DKA is resolved, what will you do now? So the child is looking well, he is also eating well, blood is good. What will you do? Will you stop the insulin? No. you will continue the IV insulin, plus you will add a subcutaneous insulin. So after adding the subcutaneous insulin, after 1 hour only you will stop the IV insulin. Okay, so this is all about DKA. You come, I'll summarize it in short. So you see a patient, you're going to assess the patient about sign and symptoms. Okay, it is diabetic ketoacidosis, you're suspecting, then you go for the test. After that you call your senior staff and you start with the treatment. If in shock or not, if in shock 20 ml per kg IV bolus, if not in shock 10 ml per kg IV bolus. Then you have to start with the total fluid. You start the total fluid according to the weight, according to the dehydration, if it is severe dehydration or mild dehydration. After that you will give total fluid. If the child was in shock, you will not subtract the initial bolus of fluid. If the child is in shock, if the child is in shock, you will not subtract. If the child is not in shock, you will subtract the fluid. Okay, the initial IV bolus. Then you have to give potassium because it causes hypokalemia. Then you have to give insulin. After that, you'll keep monitoring for the neurological deterioration, cerebral edema. If there is cerebral edema, you restrict the fluid, you give mannitol. If there is no cerebral edema, it is well and good. And then you check the blood glucose. If the blood glucose is falling, you add more glucose, you reduce the insulin, and then keep monitoring the patient and assess if the decay is resolved. If you see that patient is improving well, clinically well, drinking well, eating food, blood ketones are normal, blood glucose is good, then start with subcutaneous insulin. 1 hour you will start it before, you will start it along with the IV infusion. After 1 hour you stop the IV and do with the continue with the subcutaneous. So this is all you need to know about the diabetic ketoacidosis, and if you study up to here whatever we studied, you will be able to answer, everything, almost everything, I can guarantee you, in both FOP as well as task portions. Now let us look at certain questions, the recall questions from this topic. Okay, so this one is, forget about this first one, just look at this one. Number 11. What is the action of insulin? It moves the potassium intracellular cells. So it moves the potassium from the extracellular to the intracellular space. This was the question. Then we have 2017. What is the action of insulin? We know that it increases the fat deposition in cells, that is, it causes adipogenesis. In the second slide I showed you, it causes glycogenesis, inhibit gluconeogenesis, which is among these hormones, which is the hormone that inhibit protein catabolism. So it is a friend of protein. Which one is insulin? We have similar questions here. Mechanism of action of insulin. What is the anabolic mechanism? So they have given it causes fat deposition, synthesis of glycogen, repeat gluconeogenesis. These are all repeat questions that they have given actually. So this is all about diabetic ketoacidosis, and this is all about my demo class. I hope it was helpful to you, and I hope I have explained it well, and I've tried my best to explain it in a way that it will be understood by even a fresher. So yes, that's about my demo class. So this was all, and so as you know that I'm opening my own classes from January 1st week. So this is the details about my class. If you find my demo class interesting, and if you think that I'm the right one for you, right teacher for you, so you can join my class. The details are weekly. There will be 2 classes, Monday and Friday, 6 to 9 p.m. UAE time. I'll provide all the study materials along with past test. We'll have a weekly mock test and recall practice system wise. This is going to be a game changer. We are going to practice the recall system wise. Okay, it is designed to build a good basic, because good basics never fail. So this is my motto, good basics. I always learn basics by myself, and I make sure whoever studies whatever they study, they should have good basics in life, okay, about everything. So for enrollment, if you are interested in enrollment in joining my classes, please contact in this WhatsApp number. And if you like my video, do share with your friends, relatives, and do give a thumbs up. And thank you. That's all.